That's what we're going to be talking about, the idea of doing formal supportive therapy. The first thing, though, is we're going to start off with a question. Let's have you put this in the chat, if you can. What are the things that, what is it about psychotherapy that causes the most improvement in patients? So when we sit down and we're talking with the patient over time, what is it about that interaction that's helpful? So go ahead and enter that in the chat. If you're a really slow typist and you want to unmute and just say it, that's fine too. But if you prefer, so empathy from John Boltree, good. What else? What's helpful about psychotherapy? And I'm talking psychotherapy broadly. So the relationship. Other ideas of what's helpful, either type or speak, or just unmute. So the CBT and trust, and the CBT would be kind of these, probably the specific interventions, the cognitive interventions, the behavioral interventions. Well, let's take a look. There's a limited literature out there about this, in the motivational interviewing one. This was a study, it's 2001, but there's no reason to think that things have changed. And they looked at folks who got better over the course of therapy, and they asked, and they tried to determine what was it that made their life better. And the largest single cause was extra therapeutic change, meaning something happened outside of their life that made their life better. They got married, they got divorced, they got a new job, they moved, something happened to them. Now, that's not necessarily separate from therapy. That might have been the focus of what they were talking about in therapy. That might have been what brought them in. But it was something in their life that happened outside of therapy that actually helped them feel better. So it wasn't the therapy, well, it wasn't necessarily the therapy itself. The second biggest are common factors, or the common elements. And we're going to take a look at those. But just to round out, expectancy, placebo, is basically a placebo effect. The idea of, I'm finally going to get help. This is going to help me. That led to 15% of the improvement. And then only 15% of improvement was sticking to specific motivations. Only that 1 in 6, 1 in 7 was whether you did CBT or psychodynamic or interpersonal therapy or what kind of therapy you did, had a role, but a fairly small role. So when we talk about common factors or common elements, what are we talking about? It's those things that we were just mentioning, actually. Most of what you all put, empathy is up there, positive regard, therapeutic alliance, which we'll talk some more about, genuineness, goal collaboration, clear boundaries. This is another study from Wampold, 2015. And the way to read this is the height is the effect size that each of these factors had. So the effect it had on the patient. The width is how many studies supported that conclusion. And what you will find is that the things over to the left, and I don't know if you can read them, but I'll go through the first couple there. The highest, the biggest effect size was goal, consensus, and collaboration. The fact that the two of you, the patient and you, were working together toward the same goal. That had the biggest effect on therapy. Next was empathy. Following that, the alliance, positive regard and affirmation, a naturalistic, easy to talk to therapist, genuineness. Those are the things that really impact the patient care that we provide. Those are the things that help patients get better. Things way on the right, adherence to protocol, the specific ingredients or interventions of the therapy, much, much lower impact size, treatment differences, the style of treatment that you use. It has a role, it plays a part, but it's much smaller than those common elements. And one of the common elements, and one of the most important, is the therapeutic alliance. This defined back in Borden in 1979 as being consisting of 3 different parts. One is a warm emotional bond. You look forward to seeing the patient looks forward to seeing you. There's mutual respect and fondness. 2 is that mutual goal that's collaborative and attainable. And the third component is that there are accepted roles and expectations. They know what to expect from you, and you know what to expect from them. So let's go to that first one. We're going to give you another chance to type or to unmute. What is it that we can do to enhance that warm emotional bond between us and the patient? So when you think about being in that room with the patient, what can you do to increase the warmth? And by the way, that is not the answer. So don't do that. Be authentic, listen. Good. What else can you do? Barb, if you don't mind unmuting, when you say authentic, and authentic was on it before, what do you mean by that? I'm not disagreeing. I agree. It's absolutely correct. But what does that mean?
I mean, it was the first thing that sprang to my mind, I guess. It just that my personality is very caring. And so I mean, I don't want to say I'm Mr. Rogers, but I'm a little bit Mr. Rogers, and that's who I am. Like, I can't be cool. And so if a person, like, you can't, I can adjust myself for people, but at the same time, that's part of the wonderful building a relationship and why every therapist doesn't fit with every person. You know, I'm always going to kind of be a cheerleader because that's who I am. And I wouldn't be as good if I was trying to be something I'm not. I don't know. I'm sorry I put that in the chat.
Oh, no, you said it. No, I think you said it. I think you said it precisely, exactly right. I think that's exactly. There has to be, now. There are boundaries, there are limitations, right? But if you try to be someone who you're not, the patient picks up on that, right? The patient knows if you're playing, if you're pretending, if you're playing a role, if you're acting interested and you're not, if you're pretending to be their friend and they're going to pick up on that. So that authentic is a big part of it. So no, absolutely right. And so what are some other things you can do? So displaying sincere interest, asking about what they're interested in, what's going on. Things as simple as restatements and paraphrasing, showing that you're listening, empathic statements. And then one of the other therapeutic alliance builders is making sure that the goals for treatment are specific, measurable, attainable, relevant, and timely, so that you all are working toward the same thing together. And then roles and expectations. And there are expectations of you that you are trying to understand what's going on. You're trying to help the patient. You're trying to make helpful recommendations. You're discussing treatment options to give them control and give them a say in what's going on. You're monitoring progress and adjusting the therapy as necessary. That's what the patient has a right to expect from you. But at the same time, you have some things that you have a right to expect from the client, that they're coming to appointments, right? If you don't come to my appointments, there's no reason to think you're going to get better. That you're adhering to the treatment plan, whatever that plan is, or you're being honest and letting me know when you're not. That's okay too, but I need to know if you're not taking what I'm prescribing you, I need to know that. Be truthful in answering questions, actively participate in treatment decisions, and pay bills. As I've often explain to patients, if you don't pay me, you're not getting better. Sorry, that's just the way that it works. It's mystical, but it does happen that way. Well, and the deal is, if there are discrepancies in expectations, if there are variations in those roles or in those boundaries, that needs to become the topic of conversation. That needs to be what you focus on to get you both on the same page. Now, at this point, you might be scratching your head and wondering that the title of the talk was on supportive therapy, and all I've done so far is talk about common factors. And there's a reason for that. I don't know if you all are familiar. This is the Y model from Plaikin, Sudak, and Goldberg. And the idea was that both CBT and psychodynamic psychotherapy in particular are rooted and grounded in supportive therapy. I would, without their permission, extend the Y model a little bit and say that supportive therapy is grounded in these common elements. So when we're doing supportive therapy, an awful lot of what we're doing is building up that therapeutic alliance, helping the patient feel that we care about them, helping the patient feel understood, listened to, making sure that we're picking goals that we're working toward together. All of those things are common elements, but all of those things are essential in supportive therapy. Supportive therapy is sometimes a little bit hard to define, but I can describe it maybe better than I can define it. It's collaborative and interactive. It's not you telling the patient what to do. It's also not you sitting back being a wise guru on a hill. It's you're exchanging ideas, they're giving you ideas, you're correcting each other, challenging each other in a friendly, positive, professional way. But it's that kind of interactive experience. The goal of supportive therapy is to help people who are overwhelmed. Now, they might be overwhelmed by symptoms or emotions or circumstances. This might be a person who is chronically overwhelmed because they have a severe mental illness. It could be someone who all of their life has done well, but is now overwhelmed by something that's happened to them or to a family member. Supportive therapy directly targets functioning and distress. A lot of therapy works in an indirect way. So CBT helps depression by targeting maladaptive thought patterns. Psychodynamic psychotherapy helps you recognize patterns of relationships over time and gets you to challenge those relationships. Supportive therapy is much more direct. We look at functioning, we look at distress, and we decide what can I do in the next however long I have to help you feel better. And we're working with patients in that kind of direct way. And there's a lot of benefits to it. One of the benefits is kind of a big picture benefit. In medicine, there's an awful lot of talk, and has been for the last 40 years, about the importance of doing biopsychosocial. But when you really see what most doctors do, it's bio, kind of, it's biomed stuff. Very rarely are those providers getting involved in the psychosocial spheres of patients' lives. But supportive therapy helps us to do that, or forces us to do that. Supportive therapy is extremely flexible. You can use it in busy medication management clinics. You can use it in the emergency department and primary care, which is why we're bringing it up here. These are simple techniques that you have 5 minutes with the patient, you can do this kind of stuff. And the other reason to emphasize is because it really helps patients. I'm not going to go through the literature. There's not a huge amount. There's not thousands of articles on supportive therapy. It doesn't pay particularly well. There's no institutes out there supporting supportive therapy, but there's lots of evidence in psychiatric conditions that supportive therapy is helpful. But more surprisingly, there's evidence in physical conditions that supportive therapy is helpful. If you use these same techniques in people who have cancer and chronic pain and irritable bowel and coronary artery disease and peptic ulcer disease, they will do better. They will function better. They will feel better. So these same kind of techniques are ubiquitously helpful in patient care. Now, I'm going to go through some of these techniques, but there's a warning here first. A lot of this, I'm afraid, is going to seem very obvious or intuitive. And if it seems obvious or intuitive to you, that's because you're a good provider and you're doing this stuff naturally. You're doing this stuff because this is just how you deal with people. But not everyone does that. And it's not always practiced. Not everyone has this kind of mindset. And even if you do it naturally, it is probably best if you're doing it deliberately and intentionally. So what I'm going to do is help kind of break it down and give some kind of approaches and techniques in a very systematic way that hopefully you will find helpful. And as we go through it, you will probably see things that, oh, I'm already doing that. I'm already doing that. So again, the basic goals: minimizing distress and improving functioning. We keep that in mind all the time, that we want the patient to leave our office feeling better, or at least committed to making a change that's going to make their life better. A friend of mine, Aaron Crocker, came up with this acronym, the acronym of HOPE, that you can take supportive psychotherapy interventions and say that they are there to provide hope. The first set of interventions, you help you hear and understand their feelings and emotions. Help, number 2, organize their narrative and experience. 3, promote adaptive psychological functioning. And 4, affect change in their stresses and support systems. So we're going to walk through those. But if you keep that mnemonic in mind, when you're dealing with that patient, and again, you have 5 or 10 minutes left at the end of your session, you're not behind, you're doing well on time. Think about, what could I do to help them hear or understand their feelings and emotions, help them to organize their experiences, promote adaptive functioning, or affect change. So the HOPE mnemonic. Let me ask this, again, going to the either unmute or going to the chat. How do we help patients hear and understand their emotions? So the H is hear. How do we help patients to hear and understand what they're feeling? So if it's too long to type, you can just unmute and answer, or type it in if you got a 1 or 2 worder.
How about reflect and paraphrase back?
Absolutely. What I hear you saying was, what I think's going on. It's a nice way of showing empathy, and empathy is a way of understanding, because sometimes you'll be right and sometimes you'll be wrong, and that's okay too. Being wrong is just as helpful. So if you hear the patient's story and you reflect back, boy, it sounds like you were really scared. And they say, no, I wasn't scared. I was more angry. Don't worry about that. Lean into that. You've just learned something about the patient you didn't know. Now you can understand why they felt angry rather than scared. So just ask them about their feelings, right? How did you feel about that? What was going through your mind when you had those kinds of thoughts? That must have been really scary. Encourage them to elaborate on their story. Attend to nonverbal cues. A patient who looks sad or looks away or suddenly clenches their jaw, empathy, normalizing and validating feelings, all of those things help patients to hear and understand. And just the act of talking about your emotions is helpful. One of the things it does is it helps you think through your emotions. Very often, people come in with a jumble of emotions and I feel bad. I feel upset. Well, it's hard to work on bad and upset because they're so vague. So getting them to talk through it, when have you felt like that before? What does that remind you of? What is that like? You suddenly get them to understand, well, I guess what I am is I'm scared and I'm angry. Okay, I can deal with scared and I can deal with angry much better than I can deal with really, really upset. That's so vague. But also allowing them to talk or encouraging them to talk about their emotions convinces them that someone cares about them. Empathy helps them feel understood. Validation and acceptance decreases their sense of isolation. There are other people who feel like me. When they go through a story and they say they felt really scared, and you say, well, anyone would have been really scared in that situation, suddenly they realize they're more alike other people than they are different. And it also lets them know that you're not afraid of their emotions. You're not going to be overwhelmed by their emotions. It's okay if you cry. I'm not going to flee. I'm not going to reject you or leave you because you have emotions. We can help them organize their narrative. And this is just this idea of putting the story together in a way that makes sense, but also helping them see the big picture. There is a tendency, of course, when a patient comes in crisis, that all we focus on is the crisis. All we focus on is the problem. But there's more to their life than that problem. And sometimes it's helpful for them to see that, to put that into a larger context, to help them see that, they had a life before this problem, they will have a life after this problem, and this problem doesn't define who they are. It helps to create an explanation. If we can link their genetics or their vulnerabilities, their early childhood experiences, their lifestyle decisions, social and cultural issues, and if we can link all of that stuff to symptoms, we can let them know there were things that caused these symptoms to happen. And if there are things that made them worse, there are things that can make them better. And so what we're going to now focus on is what can we do to help you now that we understand how we got here. So this kind of makes their life more understandable, explainable, less mysterious, less out of control. We can promote adaptive psychological functioning. One of the tools here that we often forget is to ask, how have they dealt with problems in the past? What's the biggest problem that you've ever overcome? What's the biggest crisis that you successfully negotiated? And are there things you used at that time that we can use now? We can promote healthy lifestyle regulation, minimizing alcohol or drug use, getting to sleep on time, regular exercise, regular, healthy diets. We can always take time to emphasize treatment adherence. And there's some steps you can do. Ask about it. Ask about when they forget their medications. Talk about why they're supposed to take their medications, the effect of forgetting, all that kind of stuff, because we're promoting treatment adherence to promote positive functioning. And identify adaptive or maladaptive coping. So there's lots of those maladaptive coping things out there, right? Alcohol and drug use, procrastination, denial, overreacting, passivity, all of those are maladaptive coping strategies. And as the patient talks about how they've handled crises in the past or problems in the past or disappointments in the past, you will hear this pattern that they use. You can identify that and challenge them to see if they can come up with a more adaptive approach. And one of the things, the simple things really, is just problem solving. Now, all of us on this call probably have relatively good problem solving techniques, right? We can think through things and we do this automatically, but not everyone does. Some people just feel overwhelmed by their problems and don't want to think about them, or just do the first thing that pops into their head, or do whatever they did last time. And we can help them by just being a little bit more systematic about problem solving. Let's list all of the possible options. What are the pros and cons of each? What are the best and worst outcomes? Let's commit to a choice. Let's monitor the outcome and see if this works. We can always phrase things as an experiment. Okay, you hear that exercise is good. It's going to give you more energy. It's going to help you sleep better. It's going to make you feel better about yourself, but you're not sure that's true. Okay, let's give it a try. Let's try to get you to exercise regularly for the next 3 or 4 weeks. And then when I see you, we'll see how well you've done at keeping up that pattern, and we'll see if it helped. And if it doesn't help, we'll stop. If it is helpful, we'll continue. So kind of phrasing everything as an experiment. And then effects change. Once you once you've understand their story, once you've understood their emotions, understand their story, once you've looked at how they're dealing with it and what their coping styles and strategies are, then you can start looking at the sources of stress in their life. What is it that's causing you problems right now? Which of these things are in your control? Which of these things can you do something about? Now let's use our problem-solving techniques that we just developed to start addressing those and see if we can make life go a little bit better. What are the toxic relationships in your life? Let's try to cut those down a little bit. What are the supportive relationships in your life? Let's try to maximize those. What are the things coming up that might make life difficult for you? How are you going to address that? That patient who has been traumatized and the anniversary is coming up. Start dealing with that. What are you going to do on the day? How are you going to get through that really difficult day? Those kind of anticipatory guidance stuff. And then when you got the patient finally to make a change, or at least try to change, make sure that you acknowledge that this is difficult. You realize this is frightening. This isn't easy. If this was easy, they would have done it on their own a long time ago. But you're here to help them take a difficult step. You need to make sure that the patient embraces the change as their choice, not something you're telling them to do. If it's something you're telling them to do, they won't do it. It needs to be something that they want to do. Make sure that you've reviewed the likely and possible outcomes. Again, phrase it as an experiment, and then just kind of monitor it and see how it goes and check up with them the next time you see them. Okay, so I got through those fairly quickly. Good. So, because what I wanted to do is we're going to put you into breakout groups here. So I'm going to stop sharing my slides in a minute, and we're going to put you into breakout groups. And using that HOPE mnemonic, we're going to have you come up with a strategy. So here is the patient. Let's take a minute to make sure you got this patient. The patient is coming in because they have a history of hypertension, and they're just a routine follow-up appointment. This is a 46-year-old man. He has a history of hypertension, non-insulin dependent diabetes, so some risk factors there. He comes in to see his primary care doc. He has a family history of heart disease. He was laid off from work for COVID-related reasons about 4 months ago. COVID, his whole place shut down and he got laid off. He's been on unemployment since then, not really looking for work. He's expecting that eventually his job will come back. You get routine labs. You've noticed that his liver enzymes are elevated. And when you ask him about that, he acknowledges, yeah, I've been drinking a bit more. Most days, it's probably 4 to 6 per day, sometimes more, sometimes less. I mean, I have nothing else to do. I'm not going out to a bar. I'm just sitting at home drinking because it makes the day go a little bit faster. He feels, joyless and miserable a lot because, I didn't realize it, but I kind of liked my work. I kind of liked going to work and I kind of miss it. And all I'm doing now is just sitting around doing nothing. On exam and with studies, his weight, blood pressure, and blood sugars have all increased. Those are going in a bad direction. His sleep is a disrupted 6 hours per night, but that's might be because he's also napping throughout the day. Energy is kind of low. There's no thoughts of death or suicide. We're not admitting this guy. There are some money concerns within the family. The unemployment benefits are helpful, but it doesn't make up for what he was making before. He has a wife, 2 teenage kids. It's a little bit, so it's a little tight, but he's doing okay. There's really no other drug use, and otherwise he's pretty healthy except for this hypertension and diabetes. So what we're going to do is I'm going to put you into a group for, 4 or 5 minutes and give you a chance to say, what supportive goals would you have for him? So you've gone through all of that. You've gotten that history. You still have 7 minutes left in your appointment time, right? So you want to sit and talk with him about doing one thing different. Are you going to help him hear and understand his emotions and feelings? Are you going to help him to organize his narrative and experience? Are you going to promote more adaptive psychological functioning? Are you going to affect change in their stresses? And don't worry about remembering those. I will send those out to the chat, to the breakout room. So those will be there in a minute. And then we're going to give you like 5 minutes to talk about it. Come up with, and again, there is no right answer here. There might be a different approach for every person on this call, but we would like to get your opinion and maybe have one person who would enter some thoughts either in the chat or unmute when we come back. So I'm going to stop sharing.